Dr. Davis, again, I too take my hat off to you. That's just a wonderful talk, very timely, and something that we all need to be reminded constantly of. All right. There we go. So Dr. Notrika and the committee asked me to speak about the most influential pediatric papers that have come out about pediatric trauma, and sort of what papers have been influential in changing our practice in pediatric trauma across the country in the last few years. And I think I'll start with probably the most maybe not important paper, but the most important problem. Certainly the biggest threat to children's lives, morbidity and mortality, is a severe traumatic brain injury. And I personally am incredibly grateful to Dr. David Adelson, who's here in Phoenix, and his colleagues with the Brain Trauma Foundation, who sat down twice now and given us guidelines for how to manage patients with severe traumatic brain injury. So this group first got together in 2003, wrote some guidelines that were very applicable, that most all of us used, incorporated into our practice in our hospitals. And they came back together this last couple of years, re-reviewed the literature, and looked at what the real evidence was for updating those guidelines. And I'll just go through some of the highlights. What was fascinating about it is that still, even after the first guidelines were published and a decade passes, there really is very little evidence-based literature with which to make strong statements about it. And what's fascinating to me is that there is so much opportunity in this. And I'll just give a quick plug back to my friend David Notrika, who has a group of collaborative pediatric hospitals who is doing this work, because truthfully, we're never going to answer these questions from a single center in the United States. So it is important that pediatric providers and pediatric hospitals participate in these kind of trials. The first thing that the Brain Trauma Foundation group told us was that ICP monitoring is important. That you sort of say, well, duh, but the truth is that it really is not used very frequently. Of patients that should be eligible for ICP monitoring across the country in the last year, only about 38% get an ICP monitor, and the younger you are, the less likely you are to get monitored appropriately. And so ICP matters, and lowering ICP matters, and staying under the curve of 20 really does matter, and so does maintaining a cerebral perfusion pressure. That cerebral perfusion pressure target of 40 to 50 is probably right for the pediatric patient, with the younger patient being closer to 40. What's interesting about that is that what was shown in this is that driving the cerebral perfusion pressure up actually has not been shown to change mortality, but rather sort of teleologic. Those that have a CPP that's lower do better. Advanced brain monitoring, such as brain tissue oxygen monitoring, is beneficial and should be considered in pediatric patients with brain injury. 3% normal saline, specifically when compared to mannitol, is probably a better first-line medication for the patient with severe traumatic brain injury. And the doses in this iteration of the recommendations are much, much higher than they were in the last one, 6.5 to 10 cc's per kilo. Probably the best thing that they did for us was straighten out some of the confusion about head cooling. And trials have been all over the place about head cooling. Some have shown great benefit but never been able to be replicated. Some have actually shown harm, and some trials have been stopped early because of that harm. But this recommendation really does help make sense of that, and shows that if you're going to do cooling, cool early, get the patient cooled within the first 8 hours after the injury, and then maintain the cooling. It's clear that ICP goes down with cooling. Some of the problems that were seen in the early trials were that with the rewarming. They rewarmed too quickly, they rewarmed too early, and there really was a significant rebound seen during the rewarming. So if you're going to cool early, keep them down for at least 48 hours, 72 maybe even be better, and then don't rewarm too fast, not more than about a half a cc Celsius every hour. Let's see there. Going from severe traumatic brain injuries to less severe traumatic brain injuries, but probably a lot more prevalent brain injury, and much more prevalent than any of us, I think, even imagine, were concussions, and what to do about the pediatric patient with concussion. we all think of football injuries, and that's sort of what comes to mind initially, or hockey if you're in the north, or ATVs if you're, in my part of the woods, literally. But what was fascinating from this work in the Journal of Pediatrics this year was that actually the incidence was probably as high in female sports, and one of the sort of the highest incidence was in soccer. And so not something typically I would have thought of as being prevalent, but coaches, trainers, parents need to be cognizant, and if you enter into one of these activities, you need to be cognizant of the consequences, because they're not only can be devastating, but they're lifelong. The guidelines proposed here, the guidelines sort of spelled out in this Journal of Pediatrics, do state that both physical rest and cognitive rest is necessary to get over a concussion. They help you grade the injury, help you get some sense to how long patients should be out of school, how long they should be out of activity. There really is a benefit to neuropsychological testing because the patient looks pretty good, the kid looks pretty good, they're performing reasonably both athletically and in school, and yet still have significant deficits. And so testing is recommended in this group. And I think this article gives you an outstanding stepwise return to activity guideline. It really does make sense of it. And essentially, in a nutshell, what it says is that you rest for a period concomitant, sort of inversely proportional to the grade of your concussion. And then when you're ready to come back, you start with light activity, and then more strenuous activity, and then simulation of play, and then back to play. And if any time you have problems, you take a step back until you are asymptomatic at the previous step. But this article is fantastic in helping you outline that, and I really would recommend this one to you. Jump now to this article, because this article predicates many of the other articles that I think we'll talk about over the next few minutes. It really has to do with the controversy of the risk associated with ionizing radiation in the pediatric patient. There's no doubt that ionizing radiation breaks DNA, and that break in the DNA creates a missense as it tries to replicate, and that is likely to lead to missense replications are likely to lead to cancer. Now, I'm almost 50 years old, and my broken DNA from my CT or anything else that happens may get replicated, but I probably don't have that long to develop my cancer. But the 2-year-old that gets a CT with significant ionizing radiation and breaks it has 80, 90, 100 years to continue to replicate that to develop a cancer. So the question is, what's the real risk? I think this Lancet article probably gives the best answer so far to that. There are other longitudinal studies that are going on that I think are going to give us more precise answers, but this one begins to give us some sense. It's out of the UK and the National Health Service database. Over a 17-year period, all pediatric patients that had CTs for not for cancer diagnosis to begin with were followed for at least 2 years for the group that they were looking for leukemia, and at least 5 years for the group that they were looking for brain tumors, and their initial dose of CT radiation was calculated. Relative risks in those groups, the punchline of this is relative risk is increased, and the confidence interval is above 1, and so this is a real finding. And you're about 3 times more likely if you had a CT scan with at least 30 milligrays of radiation to develop a leukemia, and about 2.8 times more likely to get a brain tumor if you had a CT that was a cumulative CT of the head that was between 50 and 70. And at the time this study was done, that's only a couple of CTs. So it really doesn't take much. Their estimate is, and again, these are being revised, but it does frame much of our further discussion, is that for every 10,000 CTs that you do, we're going to cause 1 childhood cancer. So, given that, now, how do we use ionizing radiation responsibly? I'll jump out there and tell you, I'm not an anti-CT person. I CT every single day, and I use it. But I do think it's reasonable in the pediatric patient to at least justify that risk with a perceived clinical benefit. So I think the next couple of articles do just that. Pete Mazekis out of Boston worked with a AAST pediatric group and looked specifically and asked the question, can you clear a pediatric cervical spine? And specifically, can you clear one in the 2-year-old? Can you clear one in a baby that's 18 months old? They're pre-verbal. They can't tell you. I don't see them that much. I can't tell. And the question was, can it be done safely? And are there predictive factors that would lead you to believe that this one you should, this one you shouldn't? Well, so he took 22 pediatric trauma centers, level 1 and level 2 trauma centers, and looked at the incidence of cervical spine injuries and looked at the predictive values and did a regression analysis to try to figure out what those factors were that were likely to lead to cervical spine injury. First of all, fortunately, the incidence is incredibly low, and the younger you are, the less likely it is. And part of it is the younger you are, the less likely you are to make it to the hospital because your injury is usually atlanto-occipital or high, and they often stop breathing at the scene, and so don't make it to the hospital. The 4 independent factors identified were GCS less than 14 with an I component of 1, motor vehicle collision, and age greater than 2. Interestingly, age less than 2 independently did not fall out as a predictive factor for for cervical spine injury. So all these things were given point scores, and if you accumulated more than a couple of points, then the recommendation from this group was that you got your neck evaluated somehow, and that might or might not include a CT, but at least that's sort of a responsible use of the ionizing radiation because the likelihood goes up. They're at least attempting to stratify who needs it and who doesn't. And the group that had scores that were less than 2 could be cleared clinically. Now, there were some fallouts in this group. There were actually 8 fallouts, and all of them, when they went back and looked, had some physical finding that wasn't part of the regression analysis, but that should have predicted that they had it, and actually all were victims of child molestation syndrome or abuse. The Canadian group did a similar study and said, well, there's already guidelines for this in the adult population. So we've got the Nexus guidelines. We've got the Canadian cervical spine rule. Can they be applied to the pediatric population and utilized effectively to limit to identify patients with risk for cervical spine injury? So this consensus group did the meta-analysis for back to 2009 and crafted 2 separate guidelines, one for patients who were awake and alert and one for patients who were obtunded and didn't have a reliable exam. And at the end of it, came up with really these statements. They said, absolutely, it is possible in the patient who's awake and alert and who you can utilize the same criteria that you would use for an adult, the Nexus criteria or the Canadian cervical spine rule. It is possible to clinically clear those patients' necks without radiating them, either with plain films or with CT. So that gives the clinician who does this the justification and the indemnification that says if I follow some sort of pathway, specifically these pathways, that at least that group has said this is a safe thing to do. That in the patient who's awake and alert, if you needed further studies, that plain films did have value in this patient population, that you didn't have to go to a mandatory CT scan. But if you're going to scan, that's okay. But because of the radiation absorbed by both the thymus and the thyroid, which are fairly rapidly turning over tissues, scan with as low a radiation dose as possible. And I think some of these things have really pushed our industry. If you look now at our CT scanners, the new generation of our CT scanners, there's an image gently dial to them, and actually the protocols are changed so that the pediatric patient does receive less ionizing radiation. And so I think the relative risk of a CT is very, very different than it was in those previous studies that I showed before, just simply because the amount of radiation is less. Next, we'll jump from there to head scan, but similar theory. I mean, similar sort of question. What are there predictive values that I can safely discharge a patient, or I don't have to scan a patient, or who's likely to have a significant brain injury? So, PCARN group is a group of is an emergency medicine collaboration among pediatric hospitals, and they've come up with some fantastic work over the last decade, and I think this is really one of their best. They looked at 42,000 children, and about half of them are under the age of 2. So there is a cohort that's young enough to make the statements that they claim here, and they're looking at who's likely to have a significant brain injury. So the 18-month-old that comes in, I can't tell. They're irritable. They're screaming. But boy, when my 18-month-olds, if you took them away from their mother and put a collar on their neck and strapped them to a board, they were irritable too. So it's a little bit confusing, and they can't quite tell you. So what are the predictive factors that would lead to a significant complicated TBI? And they define that as needing intervention, operation, ICU, admission to the hospital for more than 2 days. That was their criteria. Again, fortunately, the incidence is incredibly low. If you just take all blunt trauma patients, you just want to roll the dice, it's less than 1% have a clinically significant brain injury. And of those, only about 10% of those that have it need neurosurgical intervention. So the incidence is incredibly low, but you can't miss it. You don't want to miss it. And they found that in a regression model that if you had these characteristics, that they had a GCS that was 15, or quite frankly, acting normal according to the family. You know, this is this kid's normal behavior. No scalp hematoma except for something in the front, a limited loss of consciousness, no palpable skull fractures, and not a significant mechanism. Now that one's a little mushy for me because I don't know what is or what isn't a significant mechanism. That's quite subjective, obviously. But if they had those characteristics, that they're actually the clinical negative predictive value was 100% there, and that those patients could safely be observed without scanning their head. So somewhat of a benefit. This paper came out of Oklahoma, the group in Oklahoma, Bob Letton and Dave Tuggle, and I think this one helped us a lot, but it also was kind of fun for me because it stood in absolute contradistinction to similar papers with the exact opposite findings in the adult literature, and it begs the question sort of why. But Bob and his group looked at 5 years of data from trauma centers that participated in the American Pediatric Surgery Association trauma subgroup, and they identified 214 patients that had blunt intestinal injury, so from a lap belt or a seat belt or a fall or being kicked or something like that, injured the intestine. And did it matter? Did time to operation matter? Because there's adult literature that says, every hour that you delay increases the mortality, and that there's a very sharp rise at some point in that curve. And Bob's group said just the opposite. They said actually no, that it was if you didn't operate when they presented with symptoms. So if they didn't have symptoms that were clinically significant, you were justified in watching them. If they developed symptoms, that's when you could take them to the operating room. And if you did that, the time was irrelevant. If you did that, actually there was no difference in morbidity and mortality. So their recommendation is that, quite frankly, serial exam is much more important than a mandatory pathway of operation, CT, DPL, anything else that you want, that the most sensitive thing was your physical examination. And if you're willing to do physical examination, it is safe to observe somebody with a blunt abdominal injury. And it's not uncommon for us. We'll talk a little bit in my next lecture about solid organ injuries. We always see the little spleen injury with a fair amount of fluid in the belly. Well, do they also have a bowel injury? Do they not have a bowel injury? They're irritable, they're crying, I can't talk to them. Well, this group tells you, put them in, observe them, examine them. If their examination changes, then your index of suspicion should go up. But there really, in their work, was no indication for mandatory laparotomy. This one's a little bit of a teaser because I'm not going to tell you the punchline until my next talk on solid organ injuries, but the Canadians have been very, very helpful to us. Siggy Ein was one of the fathers of pediatric surgery, and he 30 years ago said, you guys don't have to be operating on all these little dings on the spleen. If you'll just put them in and watch them, they'll do okay, and you don't have to operate. It was heretical, obviously, at the time, and but has been adopted by both pediatric trauma surgeons, adult trauma surgeons alike. And in 2000, the American Pediatric Surgery Association wrote a paper with Steve Stylianos as the lead author, giving us some guidelines for, okay, so who needs an operation and when do they need an operation, and what do you do with them after if you're not going to operate on them? How long do you have to watch them in the hospital and everything? And I think just like cancer treatment, where we begin with the treatment of a cancer and we throw the kitchen sink we throw the kitchen sink at it and we see a tumor regression and survival, and then we start to peel back the therapy to see if we can get the same results with less therapy. The same thing is happening at least in pediatric trauma with non-operative management and these guidelines. So Steve told us at first, how long that we needed to re-image, that they needed to stay in the hospital this long, that they need to be in the ICU, when to get blood, and when to send them back. And I'll show you the rest of the story in the next talk about where we're going with that. Suffice it to say, that's changing, and this article ends up being one of the great papers to lead that change. Again, I'm not just sucking up. I really do believe this is one of the best papers in pediatric trauma in the last several years. And I will say, when I was asked to give this talk, I got online with about a dozen trauma medical directors from around the country, level 1 pediatric trauma centers, and said, I've been asked to give this talk. I want your input on what the most influential papers that have come out recently have been. And to every one, they said, you got to talk about Dr. Notrika's paper here. So this research really looks at the impact of pediatric trauma centers. I'll regress. David and I were residents together in our pediatric surgery fellowship at Houston, and at the time we were there, if we crashed our car, we and our wives would go to a designated trauma center, a great trauma centers, 2 of them actually in the town we were in, fantastic. Our children would not. There was not a single pediatric trauma center in the state of Texas, Arkansas, Louisiana, New Mexico, Arizona. They didn't exist. It just didn't exist. And so I'm so grateful to him and his colleagues for doing work like this and bringing awareness to the pediatric hospitals that they really need to participate, that you can't be a full-service hospital unless you take care of the number one thing that kills kids. So he looked at the CDC database and correlated mortality with the presence of a verified trauma center and found that indeed the presence of a level 1 trauma center in your state decreased pediatric trauma mortality by almost 40%. I mean, there's almost nothing else we could do technically from a prevention standpoint that would have an impact like this, but having a trauma center really did, and actually having 2 made even more of a difference. We talked about screening and brief intervention and screening for domestic violence. We pediatric trauma people have a little bit of a conundrum about this, because what was fascinating is that as we strive to become level 1 pediatric trauma centers, there's this rule out there by the College of Surgeons that says, well, you got to do screening and brief intervention for alcohol. And I'm looking at the 2-year-old going, really? Do I really have to do that? But then the 17-year-old that comes in, and just off the cuff, I say, well, I just reviewed your labs and your blood alcohol was elevated. And you start talking to the kid and you realize he's got risk-taking drinking and drug behavior all the time. And you go, well, absolutely, this is what, if I don't do something about this is what's going to cause his recidivism. And this kid's going to come back in dead the next time. And so there was a strong feeling that something needed to be done, but what? And the truth is that it didn't quite seem right to use the same tools that you were using for the adult population. So one of my best friends, Paula Yuma, and the group there in Austin did this work and did a meta-analysis of all the available literature on screening and brief intervention for pediatric patients. And the results are, I think, paradoxical. They're disappointing and sort of hopeful at the same time, because what they say is that, yes, you're right, the way we do it for adults does not work for kids, does not work even for the late adolescents. The only studies that showed any positive effect really showed positive effect when you stratify it for those over the age of 18. And so there are a lot of 15, 16, 17-year-olds that are drinking and using drugs and getting and having risk-taking behavior that leads to their injury, and we don't have an effective treatment for them. And so I view this sort of a call to action, and I think we have to find this, and I do believe the pediatric trauma community is addressing this and will be effective at some point. But again, it requires all of us that do this work to collaborate, because the numbers just aren't that large. Sarah Duszinski did this work, and I think this is very important. You know, the mortality across the country for pediatric trauma is about 1.5–2%. It's very low, and we can do a lot of things to decrease that mortality, but we're going to move from 1.7% to 1.2% with a lot of effort. The injuries will usually heal. Most injuries heal. Most kids do great. And what's fascinating is that one of the biggest morbidities that they're left with is not the splenic injury or not the femur fracture, but the post-traumatic stress disorder that before I started looking at this, I'd been doing pediatric trauma for probably a decade and had absolutely no idea really existed because it doesn't look the same as it does in the adult patient population. What happens with these kids is they get quiet, they get regressive, they turn inward, and then they start having behavioral problems. Once they leave me, the surgeon, we high-five each other, and they're gone in a few days. And I see them back one time, and the mom tells the story, and I might talk to the kid, and I miss this. But the truth is that some 30% of these kids have acute stress disorder, and if left untreated, it absolutely will manifest itself as post-traumatic stress disorder, which manifests itself as depression and anger and defiant behavior, and leads to all the other sort of unwanted psychological consequences. And so Sarah put the group together and worked with a group of clinical psychologists at the University of Texas, and found that through a very simple, as Dr. Davis said, really a 3-question survey could figure out who was at risk for acute stress disorder, and found that of 124 pediatric trauma patients that were eligible to participate over a 2-year period, that almost 30% had the signs and symptoms of acute stress disorder that were likely to lead to post-traumatic stress disorder. And what that gave us the ability to do was then refer those patients to the psychologist for treatment. I'm a trauma surgeon, and I'm just not going to sit down and do acute stress disorder treatment, but I'm wrong to not have identified it and help the child or the family seek resources to get that done. What was fascinating in this was something that all of us kind of know and laugh about, was it actually wasn't correlated with the degree of injury. So the worst injured kids weren't more likely to get this. It was kids involved in motor vehicle crashes with a parent, their perception of pain, their perception of their own mortality, particularly as told to them by the parent. So the anxiety of the parent, and it really was the helicopter mom that can lead to this. And so at least that was associated with this. And sort of all of us in pediatrics joke about that, but it really is true. And so it's worth doing the screening, and it's worth picking up sort of who's at risk for this. That's just what I said earlier, that just that simple 3-question tool was effective at identifying it, and then the referral was quite simple from the trauma group. Lastly, I think if you sort of take pediatric trauma kind of a big step out and talk about doing this kind of work in disaster relief across the globe, which many of you in the room have done, this paper from Kathy Burnwhite and Steve Stylianos I think is outstanding, and it showed their experience in Haiti. And essentially what they say is that their services were very helpful in the early phase, and that not only were their services helpful, but their collaboration with the orthopedist were very helpful, because the majority of injuries that were salvageable at the time were vascular and limb associated. And they happened in the first couple of weeks. But the pediatric patient in the disaster is somewhat unique in that they're immunologically not mature, and so they're malnourished to begin with, they're immunologically not mature, and so in the next couple of weeks what they come in, and actually what the higher mortality is actually from diarrheal disease and other infectious disease and dehydration. And so there's a very predictable pattern to this that they describe in many situations, and so they talk about what kind of resources are necessary, both human resources and physical resources are necessary when caring for pediatric patients. So in conclusion, I was thrilled to get asked to do this review, and the things that I learned again in doing this were that care of the brain injured patient is evolving, and the Brain Trauma Foundation guidelines are outstanding. You should all read it. You should all incorporate it into your clinical practice. There should be a pathway in your ICU, and it should follow this, and it should be updated every time they update. You can clear a pediatric cervical spine, and again, it does help, and it does sort of indemnify you and make you utilize ionizing radiation more responsibly if you do it under a pathway. That CT scanning does have some risk to it. The absolute risk is still a little bit out there, probably the true number, but there's no doubt that there is a risk associated with it. Alcohol screening and drug screening and intervention for our patients who we probably have the greatest opportunity to impact recidivism needs a lot of work. It needs the work of pediatric providers to work in collaboration to try to figure out a way to get this done. And that long after the physical injuries are healed, the psychological injuries remain. And even though we are trauma providers and see them just for a very short period of time, we have the opportunity in the window to screen them and get them referred, because that's probably going to be one of the bigger morbidities lifelong. And pediatric trauma centers save lives, no doubt about it. Again, I just want to tell you thank you so much for having me. And I can't tell you how grateful I am to the people in the state of Arizona for what they've done and how much they've contributed to the care of injured patients through their academic work. Thank you.